Hello, here we are for Lincoln Line. We are today. We have a very special guest. It's Professor René Chapot from Alpha Group Essen at Essen. Professor Chapot, I saw you wearing a cap some months ago that says, "Let's make AVM great again."
Yes, hello. The cap was offered to me to Fatala that I just said hello to. He stayed 1 year with us as a bye-bye gift. Okay, it's really a bit Trumpy, so that's not the goal. But indeed, the text message is good because AVM is now the pathology, the disease which is less treated, and AVM, our field is exploding in AVM. We've never been able to do so many things that we can do now. So there's really a huge ability to transform today's way of treating AVMs.
And what do you think have been the advances that allow us a better treatment for AVMs from the endovascular point of view?
On many things. First of all, I would say understanding. Understanding is based on images. MR is not possible to understand an AVM on MR. Angio, yes, but angio, either we see through the guiding catheter, we see all vessels together, or we take a microcatheter and everything is so much diluted that we don't see it. And we're doing what we call 6D, which is a fusion of different volumes in different colors. And suddenly we had the impression to be able to see inside, to understand how the so-called nidus is organized, how all those veins come together. Because we can say it on a very simple way. An AVM is a connection of veins that all come together to a same vein with a lot of arteries around. It's not much more than this. And the problem is how to understand this, and it takes time, it takes effort, but we can do so. This is one thing. The other thing is transvenous embolization has been pushed forward by Itzvan Udak, by Charbel. We're contributing to the way to understand AVM by the vein is completely different. And this you realize whenever you start to do so, that when you block your vein and when you push the embolic agent, you see that you push from the trunk to all primary veins, and you understand something that you cannot understand how you get it by the arteries. So not only understanding, but the ability to cure AVMs by the artery is not so good. I mean, if it would be good, we would know. AVMs will all be cured by embolization, and the question of surgery or radiosurgery would not be as prominent as it is today. So we've got a lot to improve, but by handling techniques like pressure cooker, or let's call it plug technique, by avoiding liquid embolic to go backwards but to be pushed inside, that you determine whenever you stop or not, and not the technical limitation, which is more reflux limited. We can gain much more, but this together with access by the veins and occlusion by the veins enables to treat AVMs that are not surgical and not radiosurgical. So if we can treat AVMs that are too difficult for surgery and for radiosurgery, then no doubt that you can also treat the ones that are more easy and can be treated by surgery or radiosurgery alone.
And do you think that the difficulty or the potential difficulty of AVM, should we concentrate experience of AVM or should we democratize a little bit more?
That's a good point. AVM treatment is not simple. The first time you see an AVM, you see vessels everywhere, and you wonder, what is this? Trying to understand an AVM is trying to understand the plate of spaghetti and to understand how each spaghetti is connected to the other ones. It's not exactly this, but it takes a lot of time to invest for training, for learning, but also for each procedure. Even if you train it for many years and be doing it for many years, each procedure is a long procedure. There's nothing to do about quickie aspiration for a stroke, fast flow diversion, or web for an aneurysm. You must think on the opposite, to take as long as you need, to take hours, 3, 4, 5, 6, must be completely secondary aspect to invest enough time until you have a given understanding. And once you have understood how it looks like, then you have to find a way to proceed to get what you want.
What do you foresee for the upcoming future in Rain AVM treatment?
So what changes are going to be? First of all, this treatment is progressively enlarging. There are more and more persons that are wondering whether it should not be done, which is good. Take care is not something to be done when you've got a large AVM. So better you select indication when you start, the less there would be discussions on having a complication where someone else they've been able to treat the AVM on a better way. But I think that the technical evolutions from point of view of imaging with the Siemens 6D, 9D, I mean the fusion of different volumes is an important thing. Obviously, liquid embolics, which radio opacity disappear with time, is fabulous. Not only that we reduce the radiation dose, but once we've been treating a lot, it becomes very difficult to understand, and then we can understand it. And this is probably a way to make treatment more democratic, because if it's to be understandable, because it's visible, then it will enlarge this field, which is our goal.
Professor Chapot, thank you for your time.
It's a pleasure. Thank you.